Welcome to the Cancer Research Institute's Cancer Immunotherapy and You webinar series. Today's date is Wednesday, November 29th, 2017, and the topic for today's webinar is treating stomach, gastrointestinal, and colorectal cancers with immunotherapy. Before we begin, I'd like to thank our generous sponsors whose support has helped make these webinar series possible. Bristol Myers Squibb, with additional support from Advaxis Immunotherapies, Genentech, and Regeneron. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute, a nonprofit organization dedicated to saving more lives by funding research that aims to harness the immune system's power to treat all cancers. This work has contributed to the development of life-saving immunotherapies for a variety of cancer types, and we present this webinar series to patients and caregivers to help them understand what immunotherapy is and how it differs from other forms of cancer treatment, to provide you with the latest developments in research and treatment, and connect you to immunotherapy clinical trials. Before we get into the session today, I'd also like to let you know that we have two more immunotherapy patient summits upcoming. On December 9th, we'll be in Tampa, Florida, and on January 27th, we'll be in Houston, Texas. These are free half-day events where we bring you together with experts who will speak with you both as a group and in smaller breakout sessions about immunotherapy for a variety of cancers. You can learn more about the summit series at cancerresearch.org/summit, and if you're in those areas, we strongly encourage you to check it out. Now it's my pleasure to introduce today's immunotherapy expert. Dr. Dustin Deming, also goes by Dusty, so I'll call you Dusty from this point forward, is an associate professor of medicine at the University of Wisconsin Carbone Cancer Center at the University of Wisconsin School of Medicine and Public Health, as well as a practicing gastrointestinal oncologist at the University Hospital and the William S. Middleton Veterans Hospital. Clinically, he specializes in treating colon, rectal, and anal cancers, and has developed the concepts for and chaired several phase 1 clinical trials. Additionally, with his research and translational efforts, Dr. Deming aims to fundamentally change the way we treat gastrointestinal cancers through the development of more personalized approaches. And with that, Dr. Deming, or Dusty, thank you so much for joining us.
Thank you for having me. It's really a pleasure to participate in this webinar, and I'd really like to thank the Cancer Research Institute for this opportunity. When we think about the treatment of gastrointestinal cancers, and mainly I'm talking about colorectal, gastric, and other cancers like that, we think about standard care therapies. These standard of care therapies can include surgeries, chemotherapy, and chemotherapy of many different varieties, and also radiation therapy for many patients. More recently, and excitingly, there have been additional therapies for these cancer types, including targeted antibodies against multiple things, which we will talk about in a little further, and also new immune therapies for the treatment of these diseases. One category of new therapies that has really been broadly applicable is the use of agents that target the vascular endothelial growth factor. So this is a protein that helps the cancers induce new blood vessel growth. Drugs such as bevacizumab and ramucirumab have been approved for multiple diseases to inhibit the cancer's ability to recruit new blood vessels. And these have shown great benefits for these cancers. In addition, specifically for colorectal cancer, agents targeting the epidermal growth factor receptor have been able to inhibit the tumor growth. So these are antibodies that bind to the surface of colorectal cancer cells that have the growth factor receptor on them. And what this does is actually starve the cancer cells of signals that help the cancer cells grow. In addition, there's another type of growth factor receptor called HER2, which is more famously known for its role in breast cancer, but also plays an important role in esophageal and gastric cancers. And there are antibodies that target HER2. Trastuzumab is approved for gastric cancers that have expression of HER2 on their surface. And similarly to anti-EGFR therapies, these also inhibit the tumor growth, largely related to their ability to starve the cancer cells from the growth signals that they're getting. As you can see, with all of these new targeted therapies, they are related to specific abnormalities in the cancers. So the presence of these individual receptors, which serve as biomarkers. And when we say biomarkers, what we mean is that this is a laboratory test, largely, that helps us predict which patients are going to benefit from which therapies. So we look at HER2, specifically for gastroesophageal cancers, to see if those patients who have HER2 expression could then benefit from trastuzumab. The use of biomarkers is critically important and is something that is really a huge area of development, so that we can more personalize therapies by better understanding which patients are going to benefit from which of these therapies. Beyond biomarkers for targeted therapies, there are now immune-related therapy biomarkers. The Immunoscore, which is a test that looks at tumor tissue and the amount of T cells that are infiltrating into the tumor, has been associated with better outcomes, specifically in colorectal cancer. In addition, the microsatellite instability status has now become really a critical part of our understanding of colorectal cancer and many other cancers and the responses to immune therapies. Just to delve a little bit into that further, when we're talking about microsatellite instability, what we're really talking about is identifying cancers that have trouble fixing their DNA when mutations happen. So in all cells, as cells divide, errors happen in the DNA or the genetic code. And these errors or mutations, if your body or cells can't repair these errors, then many mutations occur. And when many mutations are present in cancers, specifically these microsatellite instability high cancers, they look really abnormal to the immune system. What this means is that the immune system is able to better detect these cancers. So in general, patients whose cancers have MSI high status, those patients have a better prognosis, and now, excitingly, have been associated with deep and prolonged responses to immune therapies. And for the first time, the FDA has actually approved therapies across cancer types, depending on their microsatellite status, which is a huge advance for these patients. The way many immune therapies work, especially the checkpoint inhibitors, as you'll commonly hear them called, they work by trying to wake up the immune system, or wake up the T cells to target the cancer. So there are things on the surface, or proteins on the surface of cancer cells, that can turn off immune cells. And many of these therapies work by trying to overcome the ability of the cancer cells to turn off T cells important for the immune response. One such group of therapies are the anti-PD-1 therapies. Examples of that class of drugs are nivolumab and pembrolizumab, which are both approved for MSI-high colorectal cancer. and pembrolizumab is more globally approved for any MSI high cancer, and more recently pembrolizumab has also been approved for PD-L1 positive gastric cancer in the treatment refractory setting. So after chemotherapy and other therapies have no longer worked, these agents have shown benefit in that setting. The graphs that we're showing here on the right, this is a waterfall plot, and this is patients with mismatch repair deficient colorectal cancer or non-colorectal cancer in the light blue and dark blue. If these lines are going down, what that means is that these are patients who responded. So this group of patients here had deep responses to single agent pembrolizumab. This mismatch repair deficiency is another way of saying MSI high. So what we're seeing is with just a single agent immune therapy, we're getting great responses for this population. Those patients whose cancers do not have MSI high status or are mismatch repair proficient, those cancers are much less likely to benefit. So that's the orange lines here. What's really exciting about this is if we look at the spider plot here, what you can see is that some of these patients, when they respond for a long time. We're talking about potentially many months to even multiple years for many of these patients. This is much different than the typical standard of care for these patients where at best we're hoping for a few months of improvement with our chemotherapy in this chemotherapy refractory setting where these patients were treated. So again, this is a very exciting advance for these patients. Combination immune therapies. So one of the exciting things is to see if we can build upon the benefit that we're seeing with the anti-PD-1 therapy alone. So specifically for colorectal cancer, the majority of the benefit that we're seeing is in this MSI high population. However, in the metastatic setting where the cancer has already spread and is not resectable, that's only probably around 3 to 4% of all colorectal cancers. And so there's still a large population of patients who we're trying to determine if they can benefit from immune therapies, but it's not going to be as easy as it is in the MSI high status. And so we're looking at ways in which we can enhance the immune response. One of them might be with radiation treatments. Radiation, especially high doses of radiation, can cause necrosis of the tumor or death of the tumor in such a way that it's potential that the radiation treatments can result in acting like a vaccine or basically trying to educate the immune system that the cancers are bad and need to be attacked. And then using the anti-PD-1 therapies, we can actually speed up the immune system to target the cancers once the immune system knows what to target. So specifically, we're actually doing a clinical trial here at the University of Wisconsin looking at SBRT, which is stereotactic body radiotherapy. This is high doses of radiation, only given over a few days, to induce necrosis and kill areas of cancer. And then that's followed by pembrolizumab, one of the anti-PD-1 therapies, and then followed by surgery for these patients. So this is specifically in patients whose cancer can be completely cut out, because we're thinking that if we can reduce the bulk of the cancer, then the immune therapies have a better chance of eliminating what's left. This is also being combined with some of the targeted therapies that we talked about previously, including anti-VEGF therapies. So there's exciting data that targeting VEGF can actually enhance the immune response. We think of this as potentially targeting more of the immune microenvironment, and there's some recent exciting data in renal cell carcinoma related to the combination of a VEGF targeted agent and anti-PD-1 therapy, and there's also promising data coming in GI malignancies as well, though that's still very early. One therapy that got a lot of excitement about a year ago at ASCO, one of our big clinical oncology meetings, is the combination of a MEK inhibitor and an anti-PD-L1 checkpoint inhibitor. What we think is going on is that the MEK inhibitor, which targets downstream in the cell from that epidermal growth factor receptor, it can actually have effects both on the cancer cell, but potentially also on the T cells or the immune cells. From a cancer cell standpoint, it looks like the MEK inhibitor can increase the number of signals on the surface of the cancer cell, telling the immune system that the cancer cell is abnormal. In addition, the MEK inhibitor appears to have some positive effects on T cells, allowing these T cells to be more active and allowing the anti-PD-L1 therapy to stimulate a greater response. And so what you can see on this spider plot is for patients with microsatellite stable, so these are not the MSI high patients. There's a subgroup of patients who seem to benefit from the combination of the MEK inhibitor and the anti-PD-L1 inhibitor. And excitingly, these responses are durable. So we're talking about many of these patients who responded then being able to have a durable response for over a year. And again, this is compared to most standard therapies in this setting only working for a limited number of months. Another exciting combination and specifically in that microsatellite instability high population is kind of dual checkpoint blockade, meaning targeting two of these signals that interact between the cancer cells and the immune cells, anti-PD-1 therapy and anti-CTLA-4. And in this waterfall plot, what we see is that there was an overwhelming number of responses to this combination in microsatellite instability high colorectal cancer. So it's not clear which of our MSI high patients we should do this dual combination in, but boy, it's exciting to see waterfall plots looking like this. Of note, when you do the combination, there does appear to be more toxicities, but there are multiple studies looking at better ways in which we can dose these drugs to limit these toxicities, but hopefully still have a similar efficacy. There's also some new therapies that are very exciting. At this last year's ASCO, data from Genentech was presented looking at their CEA-TCB bispecific antibody. So this is an antibody that binds CEA, which is a protein made by many GI cancers, including colon cancer, stomach cancer, esophageal cancer, even some pancreas cancers make this. And then also targeting CD3, which is a marker on some of the T cells. And so really what this antibody is doing, what we think it's doing, is bringing the cancer cells and the immune cells in close proximity so that the immune cells have a better way of recognizing them as abnormal. And there was early data showing benefit to this, again, in that microsatellite stable population. One thing that my lab focuses on is trying to understand better how these immune cells, or T cells, can get into cancers. And we have really been interested in a part of what we call the tumor microenvironment, or you can kind of think of it as the tissue around the cancer cells within the tumor. For years, many people have thought about this kind of what we call stroma or microenvironment as just kind of excess tissue around the cancer cells that really didn't have a whole lot of function. But what we're realizing is that the microenvironment, or the stroma, plays a critical role in the ability of immune cells to recognize cancers as being abnormal. Part of this microenvironment is a protein called Versican, or what we call VCAN. And we can see that that is present commonly in colon cancers throughout the stroma, or the microenvironment. So you can see cancer cells here, and then around this cancer cells we can see that we're staining for this Versican in patient tumor samples. Recently, what we found is that the body is able to break down this Versican, which actually has been shown to have immune regulatory properties, so decrease the ability of the immune system to see the cancer as abnormal. The body has enzymes that can cut this Versican to a small fragment called versicine. And when we stain for the versicine, we can see that there is a subset of colon cancers that have high amounts of versicine. Excuse me. This versicine is very exciting because, different from the versican, which is immune regulatory, versicine is actually immune stimulatory. And so it counteracts the effects of the versican. And if we look at tumors that have high amounts of versicine and low amounts of this versican, what we call this proteolysis predominant group, so the group that has low amounts of the immune regulatory protein and high amounts of the immune stimulatory fragment, we see that CD8 T cells are able to infiltrate those tumors much better. And so we're hopeful that this will be a biomarker for immune therapies, potentially finding cancers, and not just colon cancer. We're seeing this in many different cancer types now. This may find the patients who immune therapies have a better chance of working. The other thing that we're excited about is, well, are there ways that we can augment this system? Can we enhance the enzymes that cut versican such that there's more versicine? Excuse me. And so that's a very intense area of research in my laboratory. Another area that's gained a lot of excitement over the last 5 to 10 years is the microbiome. When we refer to microbiome in general, what we're meaning is the bacteria or other bacteria-like things that are in our colon and on our skin. Specifically in the colon, it's been shown that the microbiome plays an important role in educating the immune system. And in addition, certain bacteria have been associated or correlated with increased risks of cancer. What it appears to, as far as immune therapies are related, what appears to be the case is having a diverse or many different bacteria types in your colon is important. And it might be that this is the case because you need many different types of bacteria to really educate a healthy immune system. And so there's been studies that have shown that if you have low diversity, or you have many similar bacteria in your intestine, but not the wide varieties that we want to have, that actually decreases the immune response. Similarly, antibiotics given around the time of immune therapies can decrease this diversity and potentially can decrease the efficacy of immune therapies, though a lot of studies still need to be done to confirm that and help us figure out what the best way to understand the microbiome and how to benefit patients with cancer undergoing immune therapy still has yet to be determined. We get a lot of questions about, well, should I not be taking antibiotics? Should I be taking probiotics? Things like that. I think from the antibiotics side of things, if you don't need antibiotics, I think for many different reasons, people shouldn't be taking them. Now, if there is an infection going on, which commonly happens with people with cancer for a variety of reasons, then it's important to treat those infections. But we will learn, hopefully, how to limit the impact of those antibiotics on the bacteria in the intestine and also the impact on immune therapies going forward. So this is an area of very intense research, and I think will be a really exciting area of advancement in the future. Regarding the probiotics, we don't know that probiotics actually help the immune response or help prevent cancers. What I would recommend, though, is more of a well-balanced diet. So eating many different types of foods can really help populate your intestine with diverse bacteria. So in the future, I think actually now and in the future, I think immune therapies are only going to grow for the treatment of pretty much all cancer types. A deeper understanding of how the immune cells are interacting with cancers, or how cancers are able to evade or hide from the immune system, will really help us enhance our therapies and allow us to discover additional therapies and additional biomarkers. One of the things that I think right now is critically important for patients with cancer is to understand their MSI status. So if you have a GI cancer or loved one with a GI cancer, they need to know whether or not their cancer is MSI high or what we call mismatch repair deficient, because that really leads into some of these immune therapies for that particular type of cancer. And so at our center, what we recommend is everyone diagnosed with a gastrointestinal malignancy undergo some form of MSI testing or mismatch repair testing. So again, thank you to CRI for this opportunity, and look forward to answering any questions.
Thank you so much for that, Dusty. I failed to mention at the very beginning of the webinar that you yourself have a personal involvement in cancer. Would you mind sharing just briefly what that experience has been for you?
Sure, I'd be happy to. So when I got into medical school, I started working with a GI oncologist, and I fell in love with GI oncology. I knew this is what I wanted to do. Specifically was focusing on colorectal cancer. At the end of my fellowship, I did additional training to do basic science research, and during that time, just as I transitioned to my first faculty position as a colorectal cancer researcher and expert, I myself was diagnosed with rectal cancer. So I was diagnosed with stage 3 rectal cancer, underwent chemotherapy, radiation, surgery, about a year's worth of treatment. Thankfully, I'm now over 5 years out from that diagnosis. And so that experience has really changed my outlook in pretty much every aspect of my life. I don't think anybody can hear the C word, as we call it, without it really having a big impact on them. Specifically, I really value my time with my kids, value the time with my wife, and understand that just doing simple things at home. When you hear the cancer word, that's all you want to do is do those simple things at home and not have to worry about it anymore. From a patient side of things, it's been incredibly rewarding to be able to look my patients in the eye and say, I've been there. That treatment that you really don't want to have to go through, that big surgery that we're talking about, I've been there. And life doesn't stop after going through these types of procedures. I can tell you all the dirty little secrets about how you get through this type of chemo or that type of chemotherapy. I can tell you how bad the cold sensitivity of oxaliplatin is, because I had oxaliplatin and then I stuck my hand in a snowbank just to see how bad it could get. And from a research side of things, I now understand the urgency much better than I ever did before. And so just because an experiment could wait till next week doesn't mean it should. And I think that's really helped drive things forward in my lab.
That's such a powerful story, and I'm sure it means a lot to the patients that you're treating, as well as inspires the others working, your colleagues, to also have an appreciation for the urgency. As we all know, every day that passes is a day that we could lose more lives. So that there's definitely an urgency. You mentioned at the beginning of your talk, you showed us a bit of a difference in benefit for patients that were treated with standard, or you mentioned that conventional treatments usually only can provide only a few months of benefit versus some of the patients on immunotherapy getting a year longer. Of course, every patient response is different, and everyone's going to respond differently to different treatments. But kind of in your view, has the situation improved for patients with these types of cancers?
So overwhelmingly, over the last 10 years, we've gotten much better at treating all GI cancers. And we're seeing people living longer than they ever have before. Specifically related to immune therapies, what we see is that it's only, for most GI cancers, unfortunately, a small percent of patients that do benefit from these therapies. But when they do, they can actually really benefit from them for a long time. And I think that's what really excites us about the immune therapies, is that the responses are much more durable than typical chemotherapy. Now, I wish they worked for everybody, and I think that's a big part of the research that needs to go on, is how do we make more patients respond to these immune therapies. But the exciting thing that we're seeing now is that when people do respond, the response tends to be very durable.
Yeah, that's certainly a very active area of work that the Cancer Research Institute is doing, not just in colorectal or gastrointestinal cancers, but many different types of cancers. We do believe that this is just the beginning, and as we carry out more research, we will find ways that more patients can benefit. And we believe that day is going to come, so we're excited about that. You mentioned a side effect of one of the drugs you received as part of your treatment. What's the potential side effect profile for treatment with immunotherapy?
So I would say, in general, immune therapies tend to be better tolerated than what we classically think of cytotoxic chemotherapies. But I also caution that they're not without significant toxicities. And so many of my patients undergoing immune therapies will still get significant fatigue, rash, and still can get some of the classic chemotherapy type side effects of nausea, vomiting, and diarrhea. Though I think overall it seems to be less than with typical chemotherapy. The Big difference between chemotherapy and immune therapy is the immune-related adverse events, or what can happen is that in some instances, usually less than 10% for most of our therapies at the doses that we give now, the immune system can target some of the normal organs, and such as the hypothalamus or the thyroid gland, or potentially even the lungs or colon. And some of these side effects can be more severe. However, one of the great benefits of us having given these therapies now for a number of years is we're getting much better at treating these side effects and recognizing them sooner. So when we do recognize that these things are happening, intervening with steroids or other measures really can help mitigate the risk to patients.
You mentioned that any patient diagnosed with a colorectal cancer, for instance, should have his or her tumors profiled to see if they have that MSI instability, and therefore might make them a good candidate for immunotherapy. Is that a standard screen, or is that something that a patient needs to self-advocate for and ask their oncologist? I've heard about this, and we need to have this test done.
So it should be a standard test. It's present within all of the available national guidelines, but unfortunately it's not being done routinely in all practices. So it's unfortunate that not every oncologist is doing this as early as they should. Many oncologists are waiting till they don't have other treatment options and then thinking about doing this testing. But for me and at our institution, what we recommend is as soon as someone has a diagnosis of colorectal cancer, we should be doing the MSI or mismatch repair deficiency testing. It helps us in a number of ways. In the localized setting, it helps us understand the risk of recurrence, because in general, people with mismatch repair deficient cancers, their cancers are less likely to recur, and the benefit to some chemotherapy may be less for those patients. There are new exciting clinical trials looking at immune therapies in the earlier stage setting, and so having that testing done early would allow those clinical trials to be potentially available to patients. And then the other thing is it's important to understand the risk of this being a hereditary cancer. And so as you mentioned with Lynch syndrome, if we identify a cancer that has mismatch repair deficiency, which could be characteristic of Lynch syndrome, that may provide valuable information for that patient's family about the risk of this being a hereditary cancer. Not to mention in the metastatic setting, also the benefit of these therapies in that setting as well.
So sounds clear to me that this is a very important test for these patients with can affect not only their prognosis but also their entire treatment course. But it's a good segue into my next question, which is at what point does a patient consider receiving treatment with immunotherapy? Is it at the end after they've exhausted all other options, or is it earlier on in the treatment process?
So the honest answer is we don't know for sure what the best situation is yet. For some cancers, the FDA approval determines a lot about when they can be given. So for gastric cancer and the recent FDA approval of pembrolizumab, that is for the late line setting. So specifically for that disease, it's recommended the patients receive other chemotherapy prior to immune therapy. Now in the MSI high setting, I would say the majority of patients are getting that immune therapy after chemotherapy, but it's a very active area of research, and there are multiple clinical trials going on to try to address that very question.
One of your data slides, some of the lines represented stable disease, and I want to talk about that within the context of how patients respond to immunotherapy and whether or not doctors and patients know whether a treatment's working. So we talk about complete responses and partial responses and then stable disease. Can you tell us a little bit more about what stable disease might mean in terms of the immune context?
So stable disease, just in general, means that the cancer is not growing or it's growing to a very limited extent. At least what we see when we look at CT scans, which is the primary way that we are judging the disease stability. So just looking at, has the size of the cancer changed on the CT scan. In general, with all therapies, if the cancer is stable, then we're pretty excited because we know cancers grow, and many times cancers grow pretty rapidly. So any therapy that's keeping the cancer stable, as long as the patient's tolerating it, is a beneficial therapy in my eyes. Anything that's helping prolong time is a good thing. Specifically with immune therapy, it's interesting in that what multiple studies and in multiple settings have shown is that we can get confused on CT scans about what's actually in the tumor. And it's possible that for some patients, the immune cells kind of infiltrating the tumor can make the tumor look like it's not shrinking when actually the immune system is fighting that cancer. And so we're trying to come up with new and better ways of doing imaging for patients with cancer so that we don't get confused about that and not understand that a patient's responding to therapy even though the cancer might grow or might be stable.
Some of the very earliest studies of immunotherapy, which happen largely in melanoma, I've heard stories from melanoma experts who've told me that they've been treating their patients, they run the scans, the tumors appear to be growing, but the patient says, I feel better, like I feel so much better. So I think also that has kind of risen to the surface that patients really need to communicate with their doctors about how they feel. It's not just what shows up on the scan, and there's a lot of work I know being done to improve the way we image immune responses to tumors so that we can tell whether or not it's actually working if those tumors aren't changing in size. But how a patient's feeling can sometimes be very indicative, I think. Is there an example of when that's not true?
So in general, when patients are responding to therapy, they feel better. Sometimes, so I think the concern is though that there are some people who are having some toxicities to therapy, so they may not necessarily be feeling better, but could still be benefiting from therapy. So that is a hard area to figure out. Along those same lines as what you've mentioned with the melanoma, what's been seen or at least discussed at many of our national meetings for GI cancers is that anecdotally people feel like the next line of therapy, so the chemotherapy after the immune therapy, seems to be working better for many patients than what we would typically expect. And so it might be that because of the inadequacies of our CT images predicting response, what we're actually seeing is that some people are responding and we stop the immune therapies maybe inappropriately, but then those patients are still getting benefit in the next line of therapy.
In the past few months, there have been some approvals of a type of immunotherapy called CAR T cells, which are genetically engineered T cells. They're programmed to basically become serial killers and go after specific targets found on cancer. There hasn't been a lot of success yet in solid tumors. Is there anything happening on that front for gastrointestinal, colorectal, or stomach cancers?
So one of the big challenges with immune therapies in general for these diseases is that we have to do two things. Excuse me. We have to have a microenvironment that will allow the T cells to get in, and we have to have an ability of the CAR T cells or immune system to detect the cancer as being abnormal. one of the major problems with that for GI cancers is in many instances there's not a lot that's different between the cancer cell and the normal tissue. Excitingly, though, there are some new therapies that are in clinical trials that have shown some excitement in the preclinical literature, targeting things such as CEA. We showed the example of the CEA CD3 bispecific antibody. There's also CAR T cells that are targeting CEA, and at least in some of the very preliminary studies have shown to be fairly well tolerated and have had hints of clinical activity. So I think that's going to be a really exciting field to watch grow. I think one of the important aspects of moving that forward is trying to figure out a way to better get these CAR T cells that are educated against the cancer cells into the tumors. And so trying to better understand the tumor microenvironment and the ways that tumors are excluding these CAR T cells will be very important in the future.
Well, that's all the time that we have with you today, Dusty. I want to thank you again so much for spending time with us and talking to our audiences and patients and caregivers about the latest advances in immunotherapy for colorectal, stomach, and gastrointestinal cancers. So thank you very much. I'd like to wrap up by once again thanking our very generous sponsors, Bristol Myers Squibb, as well as Advaxis Immunotherapies, Genentech, and Regeneron. Once again, remind you of our two upcoming summits, one in Tampa on December 9th and one in Houston on January 27th. You can go to cancerresearch.org/summit to learn more about immunotherapy for many different types of cancer. Also on our website at cancerresearch.org/patients, we offer information on 20 different types of immunotherapy, 20 different types of cancer. And we also have additional resources for patients, including a clinical trial finder. If you're interested in pursuing a clinical trial of an immunotherapy for your type of cancer, come to our website and utilize our free service. All of these webinars are recorded and made available on the Cancer Research Institute website at cancerresearch.org/webinars, as well as on our YouTube channel. Dr. Deming, thank you very much, and thank you all of you for watching today. Goodbye.